Do you start?
Yeah, let's start.
Good evening once again. Welcome again. It's another Sunday, and as we all gather here, it's the thirst of knowledge. We really appreciate this. So, for today, David, something unusual. So, this was a 72-year-old male who presented to our hospital with desaturation.
Yeah, that's truly unusual. That's truly unusual to hear a presentation of desaturation. So I think this will give me a lot of problems because I do not have a good schema for approaching desaturation as desaturation. But I'll just be interested in a number of things. Because to begin with, I think the age of the patient, so it's an unusual complaint, and therefore I think my approach will not be the orthodox way of doing things. So first of all, I should say this can be anything because again, when a patient presents with a complaint or a symptom, uh, both all common diagnosis or rare diagnosis can happen. So it's just we talk of a matter of probabilities, but it can be anything. But the patient being an elderly male, of course I'll be concerned to begin with. This elderly male is desaturating. Of course, I think the age itself is not a thing, because even if it was a 20 something years old who is desaturating again, I would be concerned, and therefore I think I'll start thinking about emergencies, make sure that I rule them out, and then proceed. But overall, desaturation itself, I take it as a medical emergency, because what it tells me that this patient's blood is not well oxygenated. Now, what is the issue? Is it an issue with ventilation? So anything that you can think about that can cause respiration in general to be compromised, or is it an issue with perfusion? So, for example, a ventilation perfusion mismatch can come when you have a pulmonary embolus, for example, that is occluding. So I think I take this as an emergency, although I know again desaturation is a thing. There are also issues with the oximeter devices that we use, especially in 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 dark-skinned individuals. Sometimes it can mislead you, but then I think I'll take it as an emergency until proven otherwise. So I'll just wait to hear the HPI from you, and then I'll take it from there. But I'll start, of course, thinking about things that can immediately kill this patient, and then proceed with the rest.
Yeah, that's a good start. So the HPI, I tried so hard to put it in few slides, but it's a 60 something years HPI. So if there's any question you ask me, and I'll answer. This patient presented to our emergency, desaturating to 80s on room air, but it improved to 90s when he was put on 3 to 5 liters of oxygen via nasal cannula. So the history starts from childhood. Patient reports that since childhood to current age, he has been admitted several times in different hospitals due to recurrent pneumonias. He reports that during an episode of pneumonias, he experienced productive cough with yellowish sputum and fever. Recorded temperatures will range between 38 to 39. He also reports another history that he says he gets recurrent episode of fever, which is associated with nasal congestion, foul smelling nasal discharge, facial pain, and frontal headache that worsens when he bends forward. He also reports recurrent episode of past discharge from the left ear, which occurred in his 20s, but it resolved after 2 or 3 years. On multiple occasions, his sputum was being tested for AFB, but it was negative. But at one point, was kept on anti-TB based on suspicious chest X-ray for pulmonary TB. But he states that he used the anti-TB for 6 months, but there was no improvement on the cause of pneumonias. He kept getting the pneumonias despite being on those anti-TB. And later on, when the doctors, other doctors would think he has TB and tried to initiate anti-TB, he said no, he has used anti-TB, but he thought there was no change. He can't be on six months of medications again. But starting in his mid 40s, he would need oxygen during admissions, which was not there before. And over the next decade, the oxygen need increased to on and off at home. So he kept oxygen at his home that he would use on and off. But in his mid 60s, he became oxygen dependent to the point that I was seeing him now at 2 liters of nasal cannula, and the oxygen need increased during exertion or while he was feeding. That's a long HPI, David.
Okay, this is very interesting. Very interesting. Unfortunate for the patient, and very difficult for me. But I'll see what I can get out of it. So I'll just try to piece out a number of things, maybe connect a few puzzles and see where that can take me. So this is not something acute. So as I said earlier that when someone comes with desaturation, I'd be very concerned, and therefore make sure that I rule out uh, lethal things that can immediately kill the patient. So, for example, a pulmonary embolus would need to be ruled out if that was something acute. Also, I mean, I would take desaturation as I mean, although they do not completely intersect, but I think I would. I mean, in an emergency setting. Now, this is a general overview. Before I go back to this patient, I would take desaturation as an equivalent of Disney and treat it in the same way with Disney, and therefore make sure that I rule out all the pulmonary, all the cardiac, as well as GI causes or GI emergencies. Joseph has the 442 that he can tell you later, but you have to make sure you rule out an ACS, a tension pneumothorax, aortic dissection, a pulmonary embolus, uh, esophageal impaction, esophageal rupture, tamponade, and things like that. So, but then we come to learn that this is not a new thing for the patient. So again, we should not relax very much, but hearing that it's not the first time the patient presents this way, that tells us that we are dealing with something chronic, although the fact that this patient was at home and then decided to show up at a health facility, that means there is an acute decompensation. So we have to make sure that we rule out an acute pathology that exacerbates something that is chronic. Now, having said that, I'll go back. So, since childhood, this patient has presented with recurrent pneumonias, and there are some slides, there are some bullets there which are telling me that this patient has also been having recurrent purulent sinusitis, and yeah, that is the last bullet there, that the patient reports recurrent episodes of fever associated with nasal congestion, foul smelling nasal discharge, facial pain, frontal headache that worsens with bending forward. So that could be due to a number of things, but uh, an assumption that I make, I mean, based on that, a pattern that I recognize is a pattern of sinusitis. So when these patients, when this the frontal headache, so the specific areas of this headache, we've been told it's frontal, but then if someone gets a headache that is severe with bending forward with all these other symptoms, that makes me think of sinusitis. And because this patient is having foul smelling nasal discharge, so I'm thinking, is it a kind of purulent sinusitis? That's a probability. But then the patient, since childhood, has been having recurrent pneumonia, so that can happen with a number of conditions. So one, of course, recurrent pneumonias can lead to a complication, which is bronchiectasis. So someone can get bronchiectasis from recurrent chest infections. But again, bronchiectasis can come with primary conditions, primary ciliary disorders. So we talk of primary ciliary dyskinesia, Katagana syndrome. I'm not sure if I'm talking of different things or the same things, because or the same thing, because it's been a long time, I should admit, since I read about those things, because I have not attended a patient in whom I suspected a ciliary problem. But so I would think, because this patient presented with recurrent chest infections during childhood, it's either the patient had compromised immunity during childhood, which could be due to a number of things: malnutrition, uh, an immunocompromising disorder, whether primary or secondary. Now we've not been told. Secondary, a good example is HIV/AIDS. We have not been told about that, and of course, I'll be interested to know about it. But the assumption is maybe he doesn't have, because with these presentations, I think he has been tested many times. So that's a secondary immunosuppressive condition. So they are primary uh, immunodeficiency syndromes, of course, which I know very little about, so I will not go into the details. So I would think that the recurrent infections are either due to an immunocompromising condition, as I mentioned, there is malnutrition there, and uh, a compromise in immune status, or the patient is immunocompetent, but then there is a physical problem or physiological problem with the respiratory system and other parts in general. So one of them being the ciliary disorders that I mentioned. Yeah. So we with this presentation, I mean, the patient is now needing oxygen. History of recurrent pneumonias, presumably. He presents with, and of course, they seem like pneumonias, or at least they seem like inflammatory conditions, because the patient is presenting with fevers, presenting with productive cough, sputum production. So I think these, we are talking about respiratory infections. So a sinonasal infection, and then also probably lower respiratory tract infections, which are recurrent since childhood. Can I see the next slide? Okay, and then there is also episodes of discharge from the left ear in his 20s. Now this is so past discharge from the ear, uh, otitis externa. Commonly, I mean, otitis externa, it can present with past discharge, but not very commonly. So presenting with recurrent past discharge, that could also mean maybe there is a chronic suppurative otitis media. That would be a possibility. So we are talking about an ear infection, whether it's the outer ear or the middle ear. So otitis externa or suppurative otitis media. So these are possibilities. Now, uh, if we are talking of a ciliary problem, uh, can it be tied to this? I'm not exactly sure, because of because of my poor knowledge there, I think I would need to go and review about that. But so we see another focus where the patient is presenting with past discharge. Apart from the respiratory tract infections, which are possibly both upper and lower, we also see that the same thing happens with the ears. And of course, it's not very surprising because the ears are connected to the nasopharynx, through the eustachian tube. So sometimes an infection that involves the sinuses and the nasopharynx can also extend to involve the middle ear in this case, and therefore can lead to even perforation of the tympanic membrane and present with pus discharge, which is visible from the outside. Yeah, so now the patient later on presents with desaturation. So there is a chronic pulmonary pathology that is going on, leading to desaturation. So as I said earlier, it can be, when we talk of desaturation, we can think of anything from the airways, in which case, let's say someone has a foreign body. In this case, not very likely, because this has been there since childhood. We could be talking of an airway disease, so like COPD, especially COPD. But then, so we'll need to hear from the family social history whether this patient has been a smoker. So with the sputum production and desaturation, of course, COPDs can present that way. But we did not hear other things that are in keeping with airway disease, like a wheeze, which of course is not a prerequisite to diagnose a COPD. But then I think if we are talking of an airway disease, which we should not completely throw out, but I think we would hear maybe some elements of airway obstruction uh, presenting symptomatically. Yeah, so the patient is desaturating. I think that is airway disease is one thing to consider, although I think for some reason I am biased to think about an alveolar issue. So not just the airways themselves, but it could be involving the airways and the alveoli. So if you talk of things like I already talked about bronchiectasis, which is basically bronchiectasis again. You have dilatation and coalescing of the airways all the way to the alveoli. So bronchiectasis, I think, is one of the things that I'm considering. Although an airway disease, I'll have to think about it. An interstitial disease, would not really explain the recurrent chest infections or the sputum production. Although again, of course, if someone has a primary lung pathology, it becomes susceptible to recurrent infections. So maybe all those are possibilities that I should consider. Uh, this does not look like a vascular problem. I mean, a pulmonary vascular problem like pulmonary hypertension of any cause, because if the problem was limited to the vascular territory, then we would not expect these recurrent infections. So it would just be dyspnea and associated symptoms rather than the sputum production and all the other symptoms that we see. So yeah, I think those are my thoughts for now. Uh, Still very tangential and circumstantial. I've not been able to zero in on a particular pathology, but I think that's where I am. Can I see the next slide? Okay. So yeah, let me hear the other components of the history in order to see if I can make any progress.
Yeah, that's a very brilliant discussion. So I said I explain some things. So he came.
Joseph, you're muted if you're speaking.
Okay, sorry. Yeah, I said that's a brilliant discussion. Very nice. So I said I would explain some stuff because it's a long history. So he came to our hospital because on that particular day he came from seeing a pulmonologist who prescribed some medications, some heavy antibiotics that I needed to be in a hospital. And our hospital is close to his home, so he ordered to be admitted in our hospital so that he can receive the medication. And when I saw him, I was interested because pretty interesting, as you can see here. So review of other system, nothing significant. Past medical history also, no previous surgery, nothing significant again. Family social history is married. He has 5 adult children with the same wife. He worked as a civil engineer in road construction since his late 20s. He never worked or lived in or around mines or industrial areas. He's a lifetime non smoker. His first degree relatives are in good health, and he doesn't drink, he doesn't use any other illicit drugs.
Yeah. So the review of systems, um, the past medical history and family social history, I think they deserve some attention. Can I see? Let's start with the review of systems. So nothing significant on the review of systems.
You know.
Uh, yeah, this is of course this is a tough case for me. So what I know for sure right now is that we are dealing with a primarily a respiratory pathology, although uh, we also see the presentation in the sinuses, uh, a distant history of an ear infection, and this pathology seems to be something purulent. So definitely, I think I'll prioritize infections, but I also need to think about other inflammatory issues, that other inflammatory issues that can explain the patient's problems. So looking at the review of systems, because I mentioned something. For example, I talked about a ciliary. I talked about ciliary issues. Of course, what I know. So when you talk about ciliary issues, so for example, yes, some ciliary problems. So some of them can, I mean, they can, if we are talking of something, for example, ciliary dyskinesia. It's not only in the respiratory system. It can also affect the 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 the, the reproductive system. So, for example, people with primary ciliary dyskinesia uh, can also present with infertility because of ciliary problems, again affecting the sperm. So we see this patient is having children. So we can assume that reproductive problems maybe are not an issue with this patient. But again, of course, it's not just the reproductive system and the respiratory system. I think it also goes to the endocrine and exocrine system, even in the pancreas. So we do not see a systemic signature of this condition, but rather something that is limited to the respiratory system, both upper and lower. I'll take it to be that way. So review of systems unremarkable. Coming to the past medical history, it's unremarkable. The patient has no history of surgery. I mean, apart from this condition, which has been chronic since childhood, nothing else that is contributory. I talked about a history of smoking. This patient is a lifetime non-smoker, and we also do not see other industrial exposures, because I hinted a little bit about occupational lung diseases. Of course, although they were far-fetched, because with these, someone can have the altered physiology and anatomy in the respiratory system, predisposing the patient to recurrent infections. But again, the symptoms started since childhood, and therefore even the history of working as a civil engineer in road construction, maybe thinking about exposure to dust and all those things, I think these things are, are post-dating recurrent respiratory infections during childhood, and therefore I think the likelihood that what we are seeing is an occupational exposure is very distant. So uh, smoking is out, occupational exposures are out, and this patient and the first degree relatives again are in good health. So because there are some of these conditions, so for example, when you talk about hereditary forms of ciliary dyskinesia, I think they can run in families. The hereditary ones, they can run in families, but first degree relatives are normal, because again we have something else that I did not talk about. If you talk of things like so some kinds of COPDs, like when you talk about emphysema, when you talk about emphysema, you have alpha-1 antitrypsin deficiency, and alpha-1 antitrypsin deficiency can there can be a familial component to that. So first degree relatives are unaffected. So although yes, I mean we cannot completely throw out the possibility of alpha-1 antitrypsin deficiency just because first degree relatives are not affected. Yeah, I see Amani is mentioning cystic fibrosis. So when I talk about when I mentioned bronchiectasis, there are multiple risk factors for bronchiectasis. Ciliary dyskinesias being one of them, recurrent childhood infections, and of course infections that you can think about, including necrotizing pneumonias, tuberculosis. They can all end up with bronchiectasis. Cystic fibrosis is one of them, but then with cystic fibrosis, so of course also based on base rate, I think cystic fibrosis is not very common in our part of the world as compared, or in people in people of African origin as compared to Caucasians, for example. I think cystic fibrosis is more common in Caucasians than in Black people. Although that doesn't mean it cannot exist in our setting. But another thing is with cystic fibrosis, so that is you. So we talk about there is a membrane transporter which is responsible for exchanging chloride and bicarbonate or something like that. That has a problem, and therefore the mucus that is produced in patients with cystic fibrosis is very thick, and of course cystic fibrosis can also affect the pancreas, which we do not see in this patient. So I talked about ciliary issues. Another thing is cystic fibrosis, which can also affect. So we do not see a systemic signature of cystic fibrosis, and also the presentation. Although yes, if it presents with childhood, I mean it can lead to bronchiectasis, but I think at least the early presentation, we did not hear it. Although yes, I think it's still one of the things that I need to consider, at least from a distance. So alpha-1 antitrypsin deficiency, primary ciliary dyskinesias or other ciliary abnormalities, cystic fibrosis. Um, so the ones that are especially hereditary, I think the probability goes a little down. Although again, with things like those, you can also have sporadic cases. I mean, things not running in families, but you have a sporadic case in one member of the family. So yeah, I think those are things that I have from these other components of the history. Uh, so other things, maybe at this point, I should also talk about other things that can affect the respiratory system and can also affect the sinuses. So you have vasculitis syndromes, especially ANCA-associated vasculitis, which can involve the sinuses, can also involve the respiratory system, and of course we know them famously as uh, pulmonary renal syndromes. So, but the common presentations that we see in these patients, they present with dyspnea, yes. Hemoptysis is a textbook presentation, and then would also explain some renal manifestations, the patient is presenting with hematuria, so you see the kidneys are involved. At least from the history, we do not see kidney involvement, and again, we do not see the hemoptysis that is typical of these ANCA-associated vasculitis. So yes, sinonasal involvement and also involvement of the pulmonary involvement is typical of ANCA-associated vasculitis, but there are some features that are missing for me. So among autoimmune diseases, I think that's one of the things that I just wanted to throw out there and see what happens. So yeah, let's see the exam and see if I can make any progress.
Yeah, that's brilliant, and more brilliant for you to remember the pathophysiology of cystic fibrosis. So hard to do. Yeah, so the general exam. Patient was alert and oriented times four. He was a febrile, was not pain or jaundiced. He had no clubbed fingers, no peripheral lymphadenopathy, no rash, and no lower limb edema. Vital signs: blood pressure pulsate within normal limit, but respiratory rate elevated at 28. Temperature normal. He was starting at 80s on room air, and when you put him on 4 liters of oxygen via nasal cannula, went up to 90s. Chest exam, normal contour, trachea was central located. He had crackles throughout the chest and wheezes, but rest of the system, CVS, per abdomen, and neuro were all normal.
Okay, so I'll start with this general exam. So this patient, especially the issue of clubbing. So again, classical teaching for especially uh, for junior clerks, the issue of finger clubbing. So when we are talking about there are some lung diseases that are very typical. Uh, Typically, they do present with finger clubbing. So cystic fibrosis is one of those, and bronchiectasis in general, and of course bronchogenic tumors, uh, and other diseases like those. So uh, I mean, I do not know the test characteristics. I mean, sensitivity and specificity of finger clubbing with respect to some diseases. But because what we are seeing in this patient is a chronic respiratory problem, and especially with the recurrent, especially with the history that we had, recurrent infections presenting with productive sputum and fevers, um, and then the patient is also presenting with periods of sort of exacerbations. So I take these to be periods of exacerbations when the patient presents with increased oxygen demand and then is being admitted. I take it as such. So the absence of finger clubbing, not very surprising because I do not know the test characteristics of finger clubbing. How much sensitive and how much specific is it? So especially for an issue of specificity, I'll just say it's not very specific because finger clubbing comes with pulmonary problems like the ones I mentioned, comes with cardiac conditions like some cyanotic congenital diseases, infective endocarditis. It also comes with some hepatobiliary or GI conditions. So not very specific. I'm not sure about the sensitivity. So the patient is tachypnic. and then the patient is desaturating. We are talking about, seems we are talking about chronic desaturation. So the patient is desaturating chronically, although we see some response with oxygen. And then coming to the respiratory system, can I see the slide on systemic exam? Yeah, so there are crackles throughout and there are wheezes. So there are some things that I do not see here, which would help me conclude if this patient is having consolidation or something else, like the tactile vocal fremiters, um, the quality of the breath sounds, apart from these added sounds, which are crackles and wheezes. So uh, I cannot make a conclusion because there are some things that are missing in order to conclude whether we are dealing with the consolidation or something else. So the tactile vocal fremiters, the quality of the breath sounds, and the percussion note, as well as the vocal resonance. Of course, vocal resonance and tactile vocal fremiters are telling us the same thing, but wheezes are telling us that there is some sort of airway involvement. So especially when the expiratory wheezes, which is more common. So whatever the pathology is, what this is telling me is that there is some parenchymal involvement as well as some airway involvement, which brings out a number of things. So bronchiectasis itself, and then emphysema, which is a part of COPD. So yeah, I think those ones. But then, so other conclusions, whether we are dealing with a pneumonia, for example, currently, we cannot completely conclude because of the incomplete findings. Other systems we see they are normal. So that's what I gather so far, that we are dealing, whatever is going on, there is some parenchymal involvement because of these crackles that we are hearing. And so parenchymal / interstitial involvement, and the wheezes, the airways are also involved. So that's what I see so far. So can let's just go to the labs and imaging.
Yeah, brilliant discussion once again. So David not only discussed the case but finds fault in the presentation, which is very good. And I will tell you, we specialists, the residents, they're cracking patients better than us. That's the truth. Although your specialists will say no. If would Seba would be here, you'd see a whole slide with chest exam. Yeah, but in this platform, we don't want to lie. When I was checking this case to present, I realized I didn't do those things, so that's my bad. But it will be better later. So let's proceed. Here's the labs. ESR was raised at 67, the same as CRP, raised at 10, upper limit of normal 0.5. CBC only white count of 12, neutrophil predominance, but the rest of the CBC was normal. Chemistry, RFT, LFT, COAG, urine analysis, RBG were all within normal limit. As you're saying, yes, HIV was done multiple times previously. It was normal. This patient also, I didn't indicate here, but he came from, I'm telling you, from the pulmonologist who ordered Anna Anka initially. They are also negative with dsDNA, all of them negative. The most important is the imaging now. So I didn't do chest X-ray. Patient came with the CT and the reports, which was very nice for me. And it was written that there was marked mosaic attenuation / air trapping in the entire right upper lobe and superior segment of the right lower lobe, suggesting emphysematous changes. There was also large, thin-walled, cystic and cavitary changes in the entire left lower lobe, extensive circular or cystic dilatation of the airways in the right middle and lower lobes, and patchy septosickening. The conclusion from that CT report was emphysema. Number two, cystic bronchiectasis.
Okay. So this patient is inflamed. Uh, the both ESR and CRP elevated, and there is a slight elevation in leukocytosis. So, but especially with the inflammatory markers, because again, I do not want to send a wrong message to people. So many times we do that. I mean, people do that whenever they see a leukocytosis, they say the patient has septicemia, but we have to remember that there are lots of conditions that can elevate the white cell count, and sometimes they are not infections, they are not diseases, they are medications. So, for example, if someone uses steroids, uh, they can present with a leukocytosis. So, leukocytosis itself is not an indication of an infection or inflammation, but the inflammatory markers are ESR and CRP. So, this patient is inflamed, and so for him, I think it's important to prioritize an infection, although we have difficulties now. Joseph is telling us that this patient came for administration of antibiotics, which means antibiotics have already been prescribed. But if we were seeing this patient, I think, I mean, if we are the first responders, it would also be prudent to order a sputum culture, although we know that we have a lot of challenges with sputum culture, because the sputum itself, the way the patient is producing it, it comes out through the mouth, where we have a lot of normal flora. So it's very vulnerable to contamination, and therefore the yield may not be that much good. But I think it would be prudent if we are the first responders to send a sputum for gram staining, as well as culture, and other labs that we can offer. Although we've been told that TB was tested multiple times and it was negative. Now, of course, so with the patient is inflamed, I think prioritizing infections is a good thing. But remember that prioritizing infections, of course, it's in the acute setting. Now, this patient, so what I gather is the patient did not come with a worsening. The patient came for administration of antibiotics.
Mm.
So the patient already has antibiotics. So the issue is imaging. Of course, we expected it. You can see from the history, we had already started thinking about a possibility that we're either dealing with bronchiectasis or emphysema. So a CT scan telling us that the emphysematous changes and then there's bronchiectasis, that's not news. I think, and I suspect the reason why Joseph is presenting the case, what is the cause of this emphysema and the cause of this of this bronchiectasis. So and of course that is the standard, because many times we settle, once we make a conclusion that okay, we are dealing with bronchiectasis, we take that as a final diagnosis. But then maybe although I think I do not know enough to be very confident in that setting, but bronchiectasis itself is not a diagnosis, so it's a syndrome that is secondary to something. So you can have bronchiectasis, as I said, as a complication of some infection like tuberculosis or necrotizing pneumonia, or as a complication of some condition like cystic fibrosis, or ciliary disorders that I talked about, and many other things like again alpha-1 antitrypsin deficiency. So I think that is the task ahead of us to determine what exactly uh, led to this patient presenting with this chronic respiratory issue right from childhood all the way to the 70s. Yeah, so there is emphysema and there is bronchiectasis. But then, what is the cause? I think that's an answer that we we need to find, and I do not seem to find it. Although at this point, I should say I see the patient is inflamed. Uh, of course, after here, I'll need to go and read again about, especially about bronchiectasis and all the causes of bronchiectasis. But then, so because this patient is having a chronic respiratory problem, an infection is a likelihood leading to an elevation in CRP and ESR, or the elevation can be because of an underlying inflammatory condition. So especially autoimmune diseases, Joseph has told us that ANCA, especially the ANCA-associated vasculitis that I was thinking about, the autoimmune markers are negative. So what else? So I think if we leave aside the ANCA-associated vasculitis, I think we have a number of other things. So alpha-1 antitrypsin deficiency that can explain this patient's problems. And then a ciliary disorder, although even if you ask me, how do we make a diagnosis that this patient is suffering from a ciliary dyskinesia, whether primary or otherwise, I do not have an answer to that question. I do not know how we establish that diagnosis. But I think I'm considering a number of things, and this is the point where I would need to open a number of resources. So Harrison's one of my favorites, up to date, in order to peruse and see what exactly can explain this patient's presentation. So for an antitrypsin deficiency, a ciliary dyskinesia, cystic fibrosis. I think I would need to review cystic fibrosis and see if it can explain this patient's presentation. I think I might be wrong, but for some reason I put it very low on the list, although it's still a thing that I need to entertain. So, Joseph, where are we going next?
Yeah, so it seems like the case is ending, but it's so unfortunate. I asked this patient, so you've been rounding around with the palm. What did they say? And he told me they thought working as in road construction might be the cause of all this. I disagreed, and then I did something. I offered the patient, say, do you maybe can we pursue, because it's 60 something, 70 years old disease. Do you want to know what's happening? And it's so amazing, these patients. He said, yes, I want to know what is this, because 70 years no one ever told me. So I offered him, I said, let's send some lab to India, and we sent serum immunoglobulin profile. As you have talked, David, maybe as primary immunodeficiency syndrome, but total IgG, total IgM, IgA, they're all within normal limits. So maybe you have a diagnosis.
Okay, so maybe so something else that can I see again the immunoglobulin panel that you sent? So it was IgG, IgM, IgA. I see all of them are normal.
Mm.
Yeah. So something else that I would need to send out for this patient is I believe they call it you can check alpha 1 antitrypsin levels actually. We call it level or activity. I think you can do that. So to be honest, I do not have a specific diagnosis to commit to, but I should say one of the things that I need to consider is I would send out to I would need to know the alpha 1 antitrypsin levels or activity. For ciliary function, as I said, I do not know any diagnostic test that I could order in order to make that diagnosis. But so I think things that are on top of my list, alpha 1 antitrypsin deficiency, and then a ciliary issue. And the ciliary issue is because this patient presented with, so it's we see that this is a pulmonary issue because the emphysematous changes, there is bronchiectasis, so that means there is destruction. There's destruction, and that happens in conditions like alpha-1 antitrypsin deficiency. Again, many infections can cause that, but because this patient presented right from childhood, another thing is, so I'm also considering a possibility of a ciliary problem because of the sinonasal involvement, because of the recurrent sinusitis that the patient had. And of course, another thing that is low on the list maybe, but that we also need to consider is cystic fibrosis, in which case that is CFTR, cystic fibrosis. I think transmembrane, is it regulator or something else, but
Yeah.
it's CFTR. So I think for cystic fibrosis, you can order a CFTR gene in order to see if there is a mutation in that. So I think those are the top things that I'm thinking about, but otherwise, I am not very confident to commit to one diagnosis.
Yeah, I should say your knowledge on this palm is amazing for sure. So what I did is I was, this case also will tell you the power of schemas. I had these two schemas even before I saw this case. I read them from cases from New England, and then there'll be a case of bronchiectasis and emphysema, and I had two of them. So when I saw the conclusion from that CT, I just look at them, and if you look at both of them, three things come out. In both, there is cystic fibrosis, primary cell dyskinesia, and another one is immunodeficiency syndrome. So the diagnosis probably, first of all, I don't have a definitive diagnosis, but I can come close at least to try to tell the patient what's happening. So one of these can be the diagnosis. So you think of them. Cystic fibrosis, no one will survive to this age without treatment during childhood. Patient will die around age 14. Combined variable immunodeficiency is the one that you can have since childhood and live with it to old age, but you'll have recurrent infections and stuff. But the immunoglobulin will be low, really low. They can be zero. But these patients were normal. So that's also out. We're remaining with primary cell dyskinesia, and a lot of things can be explained in this patient, except that the patient has kids, which made me go and read about this disease. And I will share with you some teaching points that I found. So PCDK, first of all, David said this in like two slides, which is very, very nice. And I believe you get the diagnosis. It's just a lot of things in this case. So this is a congenital impairment of mucociliary clearance. It is an autosomal recessive disease, affects male and females equally. Median age of diagnosis, 5 years, which means 50% of this patient will be diagnosed below age 5. At this patient since childhood, there was this, but maybe no one thought about it. And you can do something to prevent, as we will see in the treatment, to prevent the occurrence of these oxygen needs in age 40 something. So the presentation will vary considerably. Some presentations are very like severe, some are mild, like this patient, he can live to age 70 something. 50% of this patient will have situs inversus totalis, where the viscera are on the other side of the body, but this patient didn't have this. The presentation, chronic productive cough, recurrent pneumonias in this patient, rhinosinusitis, it was there. Chronic otitis media, it was there. But the Katagana syndrome is part of it. It's when we have a triad of situs inversus, chronic sinusitis, bronchiectasis. It was not there. But if you see the study of this, it's a part of PCDK. You call it Katagana syndrome. So the infertility issue is the one that is bothering me until now. Probably we are wrong. But the literature is so clear. It says not all patients. It's 83 percent of male will have infertility and 61% of females. So we have a chance of some of them that will still have kids, but so plus or minus. And chest X-ray CT findings, there can be hyperinflation, peribronchial thickening, atelectasis, circular bronchiectasis, as you saw in this patient. Bronchiectasis is present in all adults with this disease and 50% of children. Probably this patient during childhood, if someone could have done maybe a CT, they will see the changes. And David talked about a very important issue. When these patients come, you have to do sputum culture. It will help you tell antibiotics and stop this destruction that is going on in their lungs. So most commonly, you see these organisms: Haemophilus influenza, Staph aureus, Strep pneumo, and Pseudomonas aeruginosa. Diagnosis hard. You start with screening where you use what's called a nasal nitric oxide. They blow their nose in some stuff and you measure the nitric oxide. If it's positive, if it's negative, less likely you rule out the disease. Positive, you send the patient to do ultrastructure studies. They take the samples of the mucosa and they put in the very high microscope to see the structure of the cilia. And then you do genetic studies to see the mutations that David was talking about. Management unknown, by the way, but it is individualized. First of all, treat pneumonia. The most important thing, you have to treat pneumonia properly. Every time patient comes in, like when you see today a patient is 30 and you think probably this is the disease, to prevent them to go on and have this destruction of the lungs requiring permanent need of oxygen, send sputum culture, tailor the antibiotics. You'll do a better job than maybe treating like all other pneumonias that we do uh, with the drugs that we have. Chest physiotherapy, very important to make sure that the mucus are coming up. And of importance also, this patient should be kept on chronic azithromycin prevention therapy, 500 OD for life. If destruction is too much, you have to do surgical removal, maybe lung transplant or resection of some lobes so that they won't affect other lobes. So of importance, the prognosis in this patient, they have a normal lifespan. They'll have the kind of pneumonias and stuff, but they have a pretty normal lifespan. That's why this patient is 72 and probably live like any other person. Uh, Regarding finger crabbing, David, they say it's only 8% of patients with PCDK that have finger crabbing. I don't know why, because they have to be there if you look at the pathophysiology of finger crabbing, how it comes. And I should say, um, every physician have a part that they know most, or they feel it. It's unfortunate when you're in residence, when you do that, someone say, oh, you have to be a cardiologist. No, not really. You will still be in general internal medicine. So I think pulmonology is for David. The everyone agrees here. The knowledge, David knowledge on this topic, pretty high standard. I That's very nice. Kudos to you. So maybe we hear reflection from you.
Thank you, Joseph. This was a tough case. This was a tough case. I mean, I had to summon knowledge from a decade ago. So yeah, it made me think very hard. So thank you very much for the case. And so I think so many times we enjoy the case here and the discussion, and we forget to send praises where they are due. So one of the things we should appreciate is that Joseph is doing a very good job uh, cracking difficult diagnosis, uh, attending patients, taking time, taking history, listening to patients, making difficult diagnosis that some people have given up on. So I think I personally appreciate that very much. This is not the first time I say that. you are doing a very good job. Uh, that's a very big service for the patients, because sometimes all the patient, some diseases like this, there is nothing much that you can do. But then I believe the patient, at least knowing the diagnosis, knowing what is wrong with them, that is relieving in a way. So uh, I appreciate that very much. And of course it's been a lot of learning for me today. It's been a lot of learning because I had to recall some things that I read, I think, many years ago. I've noted a lot of gaps that I need to go and work on. And of course I think it was incredibly hard, but a lot of fun for me. I think I enjoyed this case very much. So thank you for the teaching that you did. I see. I'm not sure if that was a hand raised. Uh,
Yeah, but David, before that, one
yeah,
one very good teaching point that you made, and I didn't put it in here, and everyone should learn here, is when I was studying as a medical student and even as a resident, bronchiectasis was the final diagnosis. And then when I came to read cases, that's not the case, as David is saying here. You can't say just bronchiectasis. There have to be a cause. And bronchiectasis, this is a CT findings. They're telling you bronchiectasis. That's the radiological thing. So what's the cause? It's up to a doctor now to come up with the cause. Post TB sequela or CF or any other disease. So that's very, very important point. Let's proceed.
yeah. So I saw a hand. Uh, is there anyone? And of course, in the meantime, I should say again, Amani is doing a very good job. I think he's participating very actively in these sessions, because this is not the first time I see that. Uh, Amani, I think he takes time to think what is going on with the case and sharing his thoughts in the chat. So that's very good. That's a very good thing that Amani is doing. That's a very good approach, and keep it up, Amani. Yeah. So Barton, I saw a hand from Barton. I'm not sure if that was accidental, Barton. If you have anything, okay, no problem. Is there anything else from the floor before we close? I do not see any hands. Now let me just hear from the floor if there is anyone here who hasn't joined the AfroDX link group, where we share the link, and the link both for the session and for the YouTube videos that we post. So just in case there is anyone who hasn't joined yet, I've once again shared a link to the WhatsApp group. I think that will be very easy for people, because I know there are people from many different parts of the country. And sometimes maybe someone who sends you the link may forget, but when you join that group, you have reliable access to the link, because we share it every morning before the session. And then also once we post the recording of the session, if you happen to miss the session, we also post the link to the YouTube video. So in case you haven't joined, I've shared the link in the chat. You can follow that link in order to join the group. Yeah. So if there is nothing else, Joseph, is there anything on your side?
No.
Okay, so it was good having you people around. We'll see you next weekend. Until then, let's keep learning. Have a good night.
Good night.